All right, let's dive right in. When you're in obstetrics and pediatrics, the specific words you use are incredibly important. I mean, they really matter. So today we're going to decode the essential terminology that defines the very beginning of life. So are these just labels? Absolutely not. In perinatal medicine, getting the language right isn't just an academic exercise, it's everything. These terms literally guide the clinical decisions we make and have a massive impact on the health outcomes for both mother and child. Think of this shared vocabulary as our common ground. It's our foundation. It's what makes sure that a pediatrician in one hospital and an obstetrician in another are speaking the exact same language. And that kind of consistency, it's completely non-negotiable for patient safety, for effective research, and for creating smart public health policy. Okay, so let's walk through the timeline of gestation. We've got it all laid out here, from preterm all the way to postterm. Now, the big takeaway is that every single one of these categories carries its own unique risk profile. Even that small jump from early term to full term can make a huge difference. That's why we consider full term, that 39 to 40 week window, the real sweet spot for the best possible outcomes. All right, next up is a term you're going to hear all the time, the perinatal period. What is it? Well, it's this very specific and really critical window of time, starting at the 22nd week of gestation and going all the way to the 7th day after birth. This whole period is just packed with rapid development, but it's also a time of high risk, and that's exactly why it gets so much intense medical focus. And that precision doesn't stop once the baby is born. Let's get these straight. A newborn is in their first 28 days of life. An infant is from birth up to their very first birthday. These aren't just casual terms. They are the official classifications used across the globe to track everything from developmental milestones to health data. Okay, now we're going to shift gears a little bit and talk about some classifications that are clinically vital, but also, can be really challenging to discuss. That's the topic of birth outcomes and pregnancy loss. Getting the language right here is essential, not just for effective treatment, but for having compassionate, clear communication with patients. A baby's weight at birth isn't just a number to celebrate. It's a key piece of clinical data. We always have to evaluate it in context, asking, was the baby small, appropriate, or large for their gestational age? Answering that question helps us immediately identify newborns who might be at a higher risk for issues like hypoglycemia or respiratory distress right from the start. Now, this is a crucial distinction to get right: miscarriage versus stillbirth. It all comes down to one clear dividing line, the 20th week of gestation. A pregnancy loss that happens before this 20-week mark is defined as a miscarriage. A loss that happens at or after 20 weeks is defined as a stillbirth. And to be really specific, the definition of stillbirth isn't a subjective assessment. It's based on objective clinical signs. It means that after delivery, there is a complete absence of any signs of life. We're talking no breathing, no heartbeat, and no voluntary muscle movement. So, why do we need all these super precise definitions? Well, they're what allow us to calculate mortality rates, and these rates are incredibly powerful tools. They aren't just dry statistics. You should think of them as report cards on the health of a population and on how effective our healthcare systems really are. They tell us where we're succeeding and where we need to focus our efforts. So let's look inside perinatal mortality. We can basically split it into two key components. You have early neonatal deaths, those within the first week of life, which often tell us a lot about the quality of neonatal and intensive care. Then, on the other hand, you have late uterine deaths, which happen after the 24th week. These are more likely to reflect the quality of the obstetric and prenatal care. Now, zoom in a bit, we have the neonatal mortality rate. This one is very specific. It measures deaths that happen within that critical first month of life, before day 28. It's a key indicator of how well we are caring for our most vulnerable newborns. To make that concept a bit more real, let's look at a number. In the UK, the neonatal mortality rate is about 3 per 1,000 live births. A figure like this is really important because it serves as a benchmark, allowing health systems to compare their performance and see where they can improve. Broadening our view again, we have the infant mortality rate. This one tracks deaths across the entire first year of life. And because it covers a much longer period, it's considered one of the most significant indicators of a nation's overall child and public health infrastructure. It tells you a whole lot. So what drives this rate? Well,
The three leading causes of infant death are, first, congenital anomalies, second, complications related to preterm birth, and low birth weight, which you can see highlights why our earlier definitions are so critical, and third is sudden infant death syndrome, or SIDS.
When it comes to SIDS, understanding the risk factors is the key to prevention. Some of the biggest risks include maternal alcohol use and young maternal age, but a huge factor is unsafe sleep environments, like putting an infant to sleep on their stomach or using soft bedding. This is exactly the kind of knowledge that fuels public health campaigns that save lives.
So let's bring it all together. Why have we spent all this time mastering this vocabulary? It's because these definitions are the bridge. They're what connect observing a clinical situation to making a diagnosis, choosing a treatment, and tracking massive public health trends.
This table right here is your key takeaway. Perinatal mortality, it reflects the quality of obstetric and immediate newborn care. Neonatal mortality, that's a great stand-in for the quality of our NICUs. And infant mortality gives us that big picture view of overall public health. 3 different rates, each telling its own unique and vital story.
And I'll leave you with a final thought. These definitions, as important as they are not set in stone forever. They shape everything from our research to our patient care. But as our ability to support premature infants improves and our understanding of gestation deepens, you have to wonder, which of these critical lines will be the next to change?